So, welcome everybody. Hello. I would like to welcome you to the recognition of Brain Tumor Awareness Month. My name is Jennifer Kosmal, and I will moderate today this session. So, Brain Tumor Awareness Month is an annual period dedicated to raise awareness about brain tumor, supporting affected individuals and the family, and also to promote researchers for better treatment. In the UK, the Brain Tumor Awareness Month is occurring in March, and in the US, it's observed in May. Our speaker today is on my left-hand side. It is our medical doctor, Stefaan Van Gool, with a PhD, and also he is an expert in neuro-oncology and immunotherapy. Stefaan runs the medical practice at the IOZK. The IOZK, so-called the Immune-Oncological Centre here in Cologne, Germany, was founded by Dr. Stücker in 1985, and the focus of the IOZK is here's the camera, is the immune system of the patient. The center integrates research and clinical practice, aiming to enhance the treatment outcome through innovative immune-based therapies. Stefaan joined the IOZK in 2015, brings extensive experience in brain tumor research and immunology. Before he came to the IOZK, he was a full professor and researcher at the KU Leuven in Belgium, and focusing in pediatric and adult brain cancer treatments, particular in glioblastoma. He leads research groups in immunotherapy and dendritic cell vaccine, and contributes the individual cancer treatment approaches, and received several research awards. He has published over 170 peer reviews in leading medical journals. So this is the introduction from now. So how will the session structured? At first, Stefaan will give us the presentation on living with glioblastoma, treatment options and support. Afterwards, we have a Q&A session roundabout for 30 minutes, where you can give us the questions you have. So all of you now will be muted to have minimize of interruptions, and please give all the questions in the chat. And afterwards, I will moderate and give the questions to Stefaan, who will answer it. In case you will give personal questions, please let us just also know in this chat. And just to mention it, the session will be recorded, and will be published on YouTube. So now I hand over to Stefaan, and thank you all of you that you are being here today.
So thank you very much, Jenny, and all for attending this session, Living with Glioblastoma, Treatment Options and Support, held at the Brain Tumor Awareness Month. The webinar is in fact an initiative from patients and relatives in the Brain Tumor Awareness Month, and the goal is to give information to patients about the complexity of the biology and the treatment of glioblastoma, and at the same time to give information about immunotherapy. Now, the problem if you see here, and these are the data from England that are available at the International Agency for Research on Cancer from the World Health Organization, then you can see that there are other types of cancer that are much more frequently occurring. And in fact, the brain tumors are on place 15 with this type of cumulative risk between 0 years and 74 years for males and for females. So the incidence is quite low, but the mortality is not so low. And these are, in fact, the two most important variables to estimate the burden of a cancer disease. But in fact, eventually more important is another variable that is more and more used, the mean years of potential life lost due to a particular cancer. And although the incidence of brain cancer is quite low, the mortality is in fact too high, making that the mean years of potential life lost due to cancer for both males and females is in fact the highest of all cancer types. So we still have a problem with malignancies in the brain, and we have to do all efforts to have better results. Now, how does it start? Well, a patient can have some general symptoms like reduced consciousness or headache and so on. But more importantly are a lot of localized symptoms that occur and that in fact are depending on the place in the brain where the cancer is occurring. And here you see a lot of symptoms that are correlated to the place where the cancer can occur. Once the presenting symptoms are there, the patient goes to the doctor, of course, and the doctor will speak with the patient, will try to reproduce the whole history to understand what is happening. Also, family history might be important. And then the doctor will do a clinical examination and a neurological examination, eventually to find the localization where the disease might occur. Sometimes at this stage, we already know or can suspect what type of brain cancer there might be. For instance, here as an example in children, if you have a clinical picture of neurofibromatosis with a child that has problems with visus, then you can assume that an optic pathway glioma might be the most dominant differential diagnosis. Furthermore, blood will be taken. And in the blood, you have for one type of tumors already blood tests that give you the diagnosis. Indeed, the germ cell tumors in the brain have products that you can find in the blood and that make your diagnosis already clear. If there is epilepsy, of course, an EEG can be taken, but most importantly, of course, are the imaging studies, CT scan, MRI scan, and eventually positron emission tomography. Very rare, but in MRI you can already make the diagnosis of the disease. As an example, again, the optic pathway glioma here, a tumor behind the eyes, also here, and also here. For that, you do not need a biopsy. You have your diagnosis. Earlier, not anymore now, but earlier also diffuse intrinsic pontine glioma, a very malignant brain tumor that is occurring in the brainstem, mostly in children. This could be diagnosed only with MRI, but nowadays, in fact, a biopsy of this tumor is mandatory to demonstrate the specific molecular and genetic characteristics. Then furthermore, CSF, so the fluid in the brain is taken, and this is then called liquid biopsy. But mostly we need the neurosurgeon to take a biopsy or to remove the tumor and to have a pathological and molecular biological diagnosis. The neurosurgery is aimed to take tissue and to relieve the brain from the tumor so that the patient can start the cure. So a complete resected tumor always have a better prognosis. The resection should be safe, of course, but should be as complete as possible. And there are several technologies used to help the neurosurgeon in their resection activity to get the maximal and optimal result, and also neuronavigation, awake surgery, and so on, all help to make the operation complete and safe at the same time. Some minimally invasive techniques nowadays also exist. For instance, a biopsy in the brainstem is now possible. Laser interstitial thermal therapy, endoscopic resections of tumors are rather minimally invasive techniques. And of course, not only the neurosurgeon plays a role, but also the pre, peri, and post-operative care support with anesthesiologists and intensive care medical doctors play a very important role to get the patient through the neurosurgery techniques. And then we come to the diagnosis, to the pathology. And in the World Health Organization, there are regular updates on the pathological classification of the tumors of the central nervous system. And the last classification was in 2021, including for the first time the molecular diagnostic features. You see here a lot of people who have worked together from many countries, all making this classification up to date. The most important advantage now in modern pathology is, in fact, the modern molecular biology. And in fact, each pathologist in the world can put data into this system that was developed in Heidelberg by Professor Pfister, and each pathologist can derive from this database, and AI models, classifiers, can obtain the very accurate diagnosis for the case this pathologist is trying to make the diagnosis. So this is an enormous advantage. And I have to say, Professor Stefaan Pfister is a very enjoyable person with whom I could also play a lot of music. We both are musicians at the same time. But we come to tables, and of course, the adult diffuse gliomas are the most frequent malignant brain tumors in adults. These diffuse high-grade gliomas also exist in children, as you can see here. When the diagnosis is made and the child is more than 3 to 5 years old, radiotherapy most likely is included in the therapy of malignant brain tumors. And again, a lot of technologies have been developed over the last decennia, but the external beam radiotherapy is still mostly used. Although for children, proton therapy, which makes very sharp borders of your radiotherapy field, is used more and more. There are also techniques with radiosurgery and further technologies with radioligand therapy, where radioactive molecules are put on specific targets that might be present in brain cancers, so that you bring your radiotherapy isotope in the region of the tumor. Besides radiotherapy, then we have the chemotherapy. And the chemotherapy will depend on the type of tumor. And for the malignant glioma, the glioblastoma that we discussed today in this webinar, the chemotherapy mostly exists temozolomide, An older drug is lomustine or CCNU, and there is also PCV as combination chemotherapy, and sometimes also carboplatinum or etoposide are used as second-line or third-line chemotherapy. Of course, what you do not want to have in your friends or family is such a big brain tumor, a glioblastoma, as we had here in this young female from Ukraine, even at the end of her pregnancy. It was a glioblastoma, IDH1 wild type, MGMT promoter methylated. The standard of care is surgery, then radiotherapy combined with chemotherapy, and then at the end, a maintenance chemotherapy. This standard of care has been developed based on randomized controlled trial, which gives you a level 1 clinical evidence of efficacy. That was work done by Professor Roger Stoop, published in 2005 and later on in 2009, here in the Lancet Oncology. This is a survival curve, so you have 100% of the patients that you follow over the time, and you can see the survival is going down because the patients die. In the red line, this was with radiotherapy alone. In the MGMT promoter methylated patients who are more sensitive to radiotherapy, this red line is better, so the patients die not that fast. And here you see then evidence-based the contribution of temozolomide chemotherapy in the blue line, not so much contribution in the MGMT promoter unmethylated patients that are insensitive to temozolomide, clearly better effect of temozolomide on the overall survival in the patients that are MGMT promoter methylated, thereby sensitive also to temozolomide. This is the randomized controlled trial, but it is a bit shocking to see that if 100% of the patients take temozolomide, 50% of these patients will live 27 days longer, which makes, of course, the relevance of this chemotherapy a little bit in question. And unfortunately, this method of randomized controlled trials is in fact a very old method. For the first time used in 1948, but still being the only method to create a level 1 clinical evidence. And that will be one of the challenges that we have with glioblastoma. And the challenge is very clear because we have to see that the standard of care is not changed over the last 20 years, and we should really question why is that? Well, the answer is GBM is an extremely complex tumor. And the complexity is at several levels. First of all, the tumor volume is not one type of tumor cell, but there are several subclones present, all different types of tumor cells. There are the glioma cancer stem cells. And about half of the tumor volume are in fact non-tumor cells, but dysregulated other cells that support the tumor growth, macrophages, myeloid-derived suppressor cells, microglia, endothelial cells, fibroblasts. On top of that, the genetic abnormalities are different in different tumors. And I have already spoken about MGMT promoter methylated status, sensitivity for radiotherapy, chemotherapy, or unmethylated status, insensitivity for radiotherapy and chemotherapy. And on top of that, these complexities change over time. There is a plasticity of the tumor. Tumor subclones come, tumor subclones goes, and other clones come up and go again. To make clinical trials with a control group and an experimental group, you have also to classify your patients, and the clinical classifications to make these groups of patients are very complex. Extent of resection, age, the self-performance status of the patient, the minimental status of the patients, the quality of radiotherapy that could be given. These risk profiles are summarized in the RPA classification, recursive partitioning analysis. And of course, if you make a control group and an experimental group, the patients have to be represented in both groups in an equal way. But it becomes even more complex because also within the tumor, the immune system and the interaction with the tumor has sub-classifications. So in the design of your control group and experimental group, you have also to take that into account. And on top of that, again, the immune system changes over time, as published here quite recently in 2020. If you see how the patients react already after the radiochemotherapy, this is already a big variation, and you have almost no control to design an appropriate control arm having all these biological phenomena together. So, what is the reality of a glioblastoma patient? We have already heard this tumor will give you symptoms, so you have to go to the doctor. This tumor can block in a very strong way by itself already the immune system. So what has to be done? As I have explained, the neurosurgery has to work, the radiochemotherapy has to work, and the maintenance chemotherapy has to work. And we have already said, in fact, the results have not changed, or the strategy have not changed over the last 20 years, and the results are in fact not very satisfactory. But there is something more. If we now know what I have said, that this tumor is in a very plasticity and a very active, due to the radiotherapy and the chemotherapy, you can induce new subclones. And at the same time, you weaken your immune system, that we have also seen. So that means that these new subclones, in fact, have a free path to death. And that we do for more than 20 years. So we have to change a little bit our strategy when we have to improve the prognosis of these patients. Remember, the mean years of potential life loss is highest for brain cancers. That means we should question whether such complex dynamic tumors in complex dynamic microenvironments can be treated with only surgery, radiotherapy, and one drug or two drugs from the same type. And we should question whether these highly complex dynamic tumors in dynamic microenvironments can be treated with fixed protocols in studies, because the dynamics as such are not controlled at all, and you cannot control them. So there is time to think on innovative dynamic combination treatments. Maybe you cannot anymore call them protocols, but individualized treatments. And we should start to sample real-world data. And that is what we will try to do now. First of all, we can think on targeted therapies. At least the toxicity should be less. But as I have already said, with these targeted therapies, we have a problem of the heterogeneity of the tumor. So which target should you then use? We have these different genetics, and the tumor changes over time. So the targets changes over time. So that will not work, which is in fact written here somewhere, target therapy is not appropriate for a GBM. With this tumor heterogeneity, the neuro-oncology community have realized in 2023 that maybe cell-based therapies are a solution against this tumor heterogeneity. And if you see in this publication, these are all types of immune cells. Curiously, because 10 years before, in 2013, cancer immunotherapy was already called the breakthrough of the year in 2013. And even more than 20 years ago, the first publication of a patient in Europe treated for glioblastoma with dendritic cell therapy, here are the dendritic cells, has already been published by our group at that time in Leuven. So it took a long period to realize that maybe these cell-based therapies are really important in neuro-oncology. But now the term cancer immunotherapy has been spoken. And cancer immunotherapy is in fact a very difficult word. And that is why we have again summarized in 2024 in this publication that there are several modes of immunotherapy. So if the doctor speaks about immunotherapy, you have always to ask, what do you mean with the term immunotherapy? Certainly not restorative immunotherapy. That we don't do anymore. It gives side effects and it does not work. But some immunotherapies, like passive immunotherapy and modulatory immunotherapy, they have to take into account some particularities at the site of the tumor. That is why we call these types of immunotherapy personalized. Target therapies are also personalized, but these immunotherapies are also personalized because they depend on the particularities at the tumor site. Other types of immunotherapy, like these, adoptive immunotherapy and active specific immunotherapy, they do not only depend on the particularities at the tumor site, but also at the immune identity of the patient. That is why we call those types of immunotherapy individualized. So not only the particularities at the tumor site, but also the immune system plays a role in this individualized approach. And if you combine, of course, all these types of immunotherapy, you come to the term individualized multimodal immunotherapy. Now, let's look to the first one, passive immunotherapy, a personalized type of immunotherapy. And simply the Wikipedia tells us you have antibodies, they bind to the tumor cell, an immune cell binds to the antibody and does the job to kill the tumor cell. And even with these antibodies, you can add some other elements, radioactive products, chemotherapeutic products, or bispecific antibodies. They all can function in this way. But the problem is, as I have already said, the heterogeneity of the tumor, also the blood-brain barrier, and the antigen escape. These tumors change over time and can hide their antigens and escape the role of the antibody. So antibodies that work, for instance, in breast cancer, Herceptin is a classical example, but for brain tumors, it's maybe not so a good option. Let's go to adoptive immunotherapy, which is an individualized type of immunotherapy. Adoptive immunotherapy, again, the Wikipedia, you take the tumor, you pick up the white blood cells out of the tumor, you expand the white blood cells coming out of the tumor, and you reinfuse them. Or you take blood of the patient, you do a genetic manipulation in your laboratory, you expand these cells, and you reinfuse these cells. That is adoptive immunotherapy. And there are several types of adoptive immunotherapy: lymphokine-activated killer cells, tumor-infiltrating lymphocytes. For instance, in melanoma in the Netherlands, I think this is even now an approved treatment strategy, which has really effects shown. The so-called CAR T cells, very well known by the people, or CAR NK cells, these cells are, for instance, already in first-line treatment for some types of leukemia. So they are very potent anti-cancer cells. And you have in parallel also TCR transduced T cells. So there is a lot of knowledge, a lot of evolution, and one of the leading figures have been honored with a particular prize, Carl June, for his contribution in the CAR T-cell therapy for leukemia using the CD29 or 19 as target. The problem again in brain cancer is this tumor heterogeneity. Tumors can downregulate the target, the immune suppressive microenvironment, and so on. But still, this is a very important potential technology, and we are further also working on the development of adoptive T cells, expanded T cells against CMV, and bone marrow-derived memory T cells. So here, the work is certainly not finished, but whatsoever we have in our model, not only the drugs as target therapy, but there is maybe also a future for adoptive immunotherapy and passive immunotherapy as a form of target therapy against the cancer. Another form of immunotherapy is the immunogenic cell death immunotherapy, which we call ICD. This is a novel term in oncology, immunogenic cell death, and I contributed, as you can see here, to an international group who have described the guidelines for the definition, detection, and interpretation of ICD. It is so that you can kill cancer cells in a way that there comes an immunological alarm, and that parts of these tumor cells are taken up by dendritic cells who move to the lymph nodes. And in the lymph nodes, these activated dendritic cells will then stimulate immune cells. And finally, these stimulated immune cells will go to the place where the cancer is and will kill the cancer. Immunogenic cell death, as said, is a general phenomenon that recently has been described, and there are some chemotherapy and radiotherapy techniques that in fact work over a mechanism of immunogenic cell death, as demonstrated in these two publications. We also know that the tumor treating fields Optune has in fact an effect that goes over immunogenic cell death. And this is a recent publication from Novocure, who has the knowledge on these tumor treating fields. We also know in animal models, but also in patients, that the modulated electrohyperthermia, which we give here also in Köln, can in fact induce immunogenic cell death. And we certainly know from preclinical research and clinical data that the use of oncolytic viruses, like the Newcastle disease virus that we use, can also induce immunogenic cell death. So that makes that we get a fifth anti-cancer pillar with biological treatments and physics treatments that kill the cancer cell, but at the same time can start to induce an anti-cancer immunization. Now let's go further. we have the active specific immunotherapy that are the vaccines. Some are cellular, then they are individualized. Some are non-cellular, then they are, of course, personalized against the target, but not individualized because they are not specifically directed for a particular immune system. A vaccine has always three elements: the antigen, the carrier to bring the antigen in the body, and then the danger signal to alarm the immune system. There are quite a lot of different types of antigens that can be used. There are different types of carriers that can be used, and there are different types of danger signals that can be given. A very important technology for which, if you contribute to a very large extent, for which you can get the Nobel Prize. So in 2011, Ralph Steinman won the Nobel Prize for the discovery of the dendritic cell, and Beutler and Hoffman won the Nobel Prize together for the discovery of the extremely important role of the danger signals. I know quite a lot of the audience ask, what is the difference between CGAT vaccines and the vaccines that we give? Well, here are the answers. At CGAT, and they have a very nice publication out last year in Nature Communications, so their system works. They have computer predicted well-defined antigens, but of course from the resection piece that they have received in the laboratory. They use water and dimethyl sulfoxide, and as danger signal they use GM-CSF, eventually with imiquimod, aldaraquine. The vaccines that we produce, they conclude all real antigens and actual antigens that are in the brain, but we don't know them, they are undefined. We put them on autologous mature dendritic cells from the patient, and we give the danger signals in the laboratory so that we are sure that the danger signals have their function on the antigen-presenting cell. How does that look like? Here is a model published in 2020. We can take our antigens from the tumor and bring it in the laboratory, or we can give modulated electrohyperthermia and oncolytic viruses to elicit these little antigenic extracellular microvesicles or apoptotic bodies or large oncosomes. There are several names, and we can then take those fragments out of the blood. These antigens are loaded on dendritic cells that are cultured out of the blood. White blood cells, monocytes, are differentiated to immature dendritic cells that then can receive these antigens. And then we have to make a maturation signal, the danger signal. We do that with cytokine cocktail and Newcastle disease virus. And then you have highly active dendritic cells that come into a syringe. We inject these cells intradermally in the skin of the patient. The cell moves to the lymph nodes, and in the lymph nodes, the cell will stimulate the immune cells that recognize the antigen, and these immune cells will fight against the cancer. The methodology to make dendritic cells and to load them and mature them for making a DC vaccine, I had the honor to learn that from the Nobel Prize winner himself, Ralph Steinman. And I had the chance to work with these extracellular microvesicles, apoptotic bodies, or large oncosomes here at the IOZK with the expertise of Wilfried Stucker and Professor Volker Schirmacher, who are co-working here all together. So now we can eventually solve the problem that we just have depicted, we can indeed add already at this stage ICD immunotherapy to kill also the glioma cancer stem cells, to kill eventually changing cells, to change the tumor microenvironment, to make the immune microenvironment susceptible for immune cells. And then instead of letting these clones proliferate, we can block them. In a second phase, an immunization phase, where we can elicit the antigens that exist at that time point with these extracellular vesicles. So the old antigens, but also antigens from the already newly induced tumor clones. Now we have a new layer. After the anti-cancer phase, we can start with the immunization phase with all these types of vaccines. There is more types of immunotherapy. The modulatory immunotherapy. Modulatory immunotherapy can be done with several approaches. Anti-inflammation, bisphosphonates to challenge or change your macrophages, whole body hyperthermia, but this is not for brain tumors. It gives you a general alarm of all the immune cells due to the fever. And then, of course, the checkpoint inhibitors. Checkpoint inhibitors, that is mostly what is called immunotherapy. And it works without any doubt. Here, just as an example, a study on melanoma patients. Look, here in the standard of care, almost all patients die. And here, with the use of the checkpoint inhibitors, more than half of the patients live after 5 years after diagnosis. So this is an extreme breakthrough. And of course, for that, you get the Nobel Prize. And these checkpoint inhibitors can work at the level of the activation of the immune system, giving quite a lot of side effects because they are wild activated and not antigen-specific activated. Or you can use them at the effector phase, where your activated immune cell much better can kill the target because blocking mechanisms are blocked and the immune cell is deblocked in its activity. Now, there is a problem. 2024. Investigations of checkpoint inhibitors in both newly diagnosed and recurrent GBM have thus far been disappointing. This lack of clinical benefit has been largely attributed to the highly immune suppressive nature of GBM. However, immunotherapy still holds promise for the treatment of GBM in combinational strategies. That is important. That is the way we have to go. There is an extra problem. Maybe we do not need the high doses that the companies recommend. There are more and more groups who work with low dose checkpoint inhibitors, as commented here in this comment in the Journal of Clinical Oncology in 2022. But whatsoever, in our treatment strategy, we can indeed use modulatory immunotherapy. We can use all these drugs against inflammation, and we can start to use one checkpoint inhibitor to allow the activation of CD8 T cells against the cancer. That makes that in our model, we have an extra layer. Not only the active specific immunotherapy, but also the immunomodulatory immunotherapy can already be used at the same time. And then we know that the tumor will try to escape the immune protection. So the tumor immune escape mechanisms. Again, new clones will start to appear. So we have to maintain and expand this immune protection in a third phase. And for that, we use again ICD immunotherapy. We use modulatory immunotherapy also to block T cell exhaustion so that the T cells remain active against the cancer and does not become tired. And we give peptide vaccines and boost vaccines. So the model is further extended with a third phase, the maintenance and expansion phase. But I have said the tumor is very complex and almost half of the tumor volume do not exist of tumor cells. And we know from Hanahan that there are a lot of hallmarks in this tumor microenvironment that play a role in the genesis of cancer. And if we adapt this schedule to the GBM formation, you come up with such a type of model, and we have looked in particular to 5 hallmarks of cancer that play a particular role in the genesis and maintenance support of the GBM. And these 5 hallmarks are the glioma stem cells, the hypoxia, the metabolic reprogramming, the immune response, and the neuron glioma axis. And they, again, it's a heterogeneous element within the tumor. And it changes over time, which again makes clinical trials extremely difficult, of course. I will show you some slides, but not go into detail because it becomes very complicated. But we can influence glioma stem cells and stabilize them with antidepressants. We can treat hypoxia and the effects of hypoxia, for instance, with mebendazole, melatonin, eventually also chloroquine. The metabolic reprogramming, we can target them with alpha-lipoic acid, metformin, atorvastatin. The inflammation I have already said, but here you see that this inflammation is connected to the metabolic dysregulations, is connected to the hypoxia, and so on. And several drugs can be used to approach several of these connections. And finally, very interesting, we know that the electricity of the neurons maintain the network of the glioblastoma. So if we cut this electricity from the neurons towards the glioblastoma network, then we take away the support from the neurons to the existence of the glioblastoma, and that's why perampanel nowadays is prescribed. So we end up with a whole complex combination of tumor microenvironment treatments, modulatory immunotherapy, stem cell axis, metabolic cocktail, hypoxia treatment, neuron glioma axis, psychoneuroendocrino-immunology axis, and the gut-brain axis. And that all should be combined together in the global strategy that we are using right now to treat our patients. The question is, of course, what does that do? Well, here you see some of our results. In this table at the moment, there are 5 randomized clinical trials that have been published in the last years, summarized. And all the control arms of these trials were used as external control arm in the dendritic cell vaccine trial from Northwest Biotherapeutics. And here we see the clinical risk profiles, median age, female versus male, the Karnofsky Performance Index, and then the extent of resection. We have done publications on our patient group They are not controlled trials. They are simply real-world data patients. In the first publication, we published 50. Then 1 year later, the group was bigger, so we published 71. 1 year later, in tested or analyzed in October 24, the group was bigger, so we can report on 90 patients. They are taken out of the database based on this criteria. And what we can see is that the age of our patients is maybe a little bit younger than the age of the study patients. We have maybe a little bit more females as compared to the study patients. Females have a better prognosis for immunotherapy. But on the other hand, the median Karnofsky performance index is lower in our patient group than in the studies. And we have more less than completely resected patients, which makes also the prognosis of these patients less good. So we sometimes get the critique that we have a selection bias in our patients. But if we look to the clinical characteristics, it's not at all the case. And on the contrary, the scientific community now recognizes that, in fact, patients considered eligible for phase 3 clinical trials represent a highly selected minority of patients in the real-world GBM population. So maybe the selection bias is more located here than here. But nevertheless, we can look to the prognosis and to the countries. So here you see the countries from where these 90 patients are coming. Most from the UK, as you can see. In total, we speak about 38 MGMT promoter methylated patients, so they do a little bit better, and 52 MGMT promoter unmethylated patients, so they do a little bit less good. And here you see simply the lifespan from operation to the time the patient has died for each patient in the MGMT promoter methylated group and the MGMT promoter unmethylated group. The dark lines were still alive in October 2024. The black line here is the median overall survival that you expect from the literature. And as you can see, a lot of the lines of the lifespan of our patients are longer than the median expected overall survival, and also here. And what you also can see here, for instance, is in around 2018, when we were developing our treatment model, suddenly the lines became much longer. So that means stepwise, we have done some good elements in the building of our treatment strategy, which really have given longer overall survival. If we put that on the table, as I have said, all the control arms were here put as external control arm in the Northwest Biotherapeutics trial, and that is the survival data that you can expect for the unmethylated patients. The median overall survival, that means half of the patients have died, here 40.6 months, with a percentage 2-year overall survival of 21%. In the methylated patients, it's better, 21.3 median overall survival, with a 2-year overall survival of 42%. When we now see our published data and the last update that I have made in October 2024, then you can see that there is a major shift in the overall survival. Remember, the contribution of temozolomide was 27 days. This is here in terms of months. And we have almost a doubling of the percentage 2-year overall survival. Also, in the methylated patients, it's a really shift in the median overall survival, with almost a doubling of the percentage 2-year overall survival. If we put that in curves, these are the data from Linda Liao, Northwest Biotherapeutics. The effect of the dendritic cell vaccine on its own, on top of the standard of care, in the MGMT unmethylated patients, it did not work at all. In the MGMT promoter methylated patients, it clearly worked, and the prognosis is shifted in a good direction. If we see the role of tumor treating fields on its own, and as said, I consider that as a type of immunogenic cell death immunotherapy, then you can see in the MGMT promoter unmethylated patients a clear shift as compared to the control, as you can see here. And also in the MGMT promoter methylated patients, it's a clear shift in the good direction, as you can see here. One can debate on the type of curve, which is different here as compared to here. My interpretation is that this might be more an immunology effect, while this here in the beginning might be more a cell cycle arrest effect. If we then put our overall survival curves, then they look like this, with the median overall survival and the 2-year percentage overall survival as I have depicted. We have clearly to say to the audience that observed is not the same as evidenced. This is clearly to be kept in mind. But whatsoever observed or evidenced, for the patient, it's quite clear that the therapy in total has done a good job. This patient has been published because I want also to say, using this publication, that in between you might see treatment-related effects, immunotherapy-related effects, even at the other side, as shown here in these little white spots. And of course, the Irano criteria help in the interpretation of the MRIs, but sometimes it remains extremely difficult. So for us, it means that we have this observation. Observed is not equal as evidenced, but whatsoever, every day the patient lives longer with good quality of life is as such already invaluable, even if it is only observed and not evidenced. Of course, we try to think on evidence. Should we do a small clinical trial? I don't think. Should we do a big randomized control trial? The problem is who will be candidate for the control arm. That seems not very appropriate. And on the other hand, these questions remain. So that means that, in fact, we stick on the method that we have available here in Germany with individueller Heilversuch, and we have published comments on this system, this legislation system that exists here in Germany. And the need is there, if you see to the cumulative number of patients that start treatment over years, most of these patients are, in fact, the brain tumor patients more than the digestive patients, the breast cancers, the prostate cancers, and the pneumology and gynecology. We can do that because we combine medical care and expertise with expertise in translational medicine. We have an advanced biotechnology knowledge and a good manufacturing practice infrastructure. And the regulation people help us to stick on the legislation that is available in Germany. And in practice, we let patients treat in the home country for the standard of care we add with the ICD therapies, the vaccines, and together we can give the tumor microenvironment treatments. And this is the last slide. So our building is built. Real world data can support everything. And the take home message is we should combine treatments. We should learn to think to treat GBM in multiple phases. In each phase, individualized multimodal immunotherapy and tumor microenvironment therapy should be included, and we should critically keep looking to the data and communicate these data to the scientific community in conferences and in publications. And I think with that, I can close what I want to say. I thank you for your attention.
Thank you, Stefan. And not just a thank you from my side. I see already that the chat is starting and there are some things and also some questions. So starting, we see this last slide. So maybe we'll directly go to the last question I see at the moment. So would you suggest to combine IOZK treatment, for example, with CGAT or Pan-Am vaccine?
So which
the last, so yes.
Which is to combine? Well, yes. So IOZK treatment, I don't like that word. It's in fact a very complex treatment. But the goal of the immunotherapy at IOZK and the goal of immunotherapy at CGAT or Pan-Am, they are in fact the same. So that means indeed you can combine these different approaches. The only point that I want eventually to stress is in your global strategic plan, it's maybe not so appropriate to do everything at the same time. So I would rather work in phases, and I would not personally not combine real vaccines during the period of chemotherapy, because there I think the efficacy of the vaccines is less good. If you, for instance, look also to the paper from Northwest Biotherapeutics, their vaccine for their relapse patients after the chemotherapy, they had there also quite good results. So that means chemotherapy and active vaccination is maybe a less good combination, but all these different types of vaccines all have the same goal, the same biological effects. They try to stimulate the immune system to fight against the cancer.
Okay. And would you apply the treatment for other tumor entities?
Well, immunotherapy in general is an agnostic therapy. That means it does not depend on a certain source of tissue source for your cancer. The requirement is that you have a functioning immune system and that you have tumor antigens that are recognized by the immune system. So yes, also for other types of cancers, such technology can be used. And as I have shown in my slides, besides the brain tumors, we have also digestive tumors like colorectal cancers, pancreas cancers, gastric cancers, esophageal cancers. We have the different types of breast cancers. We have the urology, prostate cancers, kidney cancers, urothelial cancers. We have the gynecology, ovarian cancers, cervical cancers, endometrium cancers, the non-small cell lung cancers, the small cell lung cancers. They all can be approached with such a technology, at best already in combination with the first-line treatment.
So a specific question for the location. So if GBM is infiltrating corpus callosum, in which case resection surgery is indicated?
Well, related to surgery, I'm myself not a neurosurgeon. I know the risk of safety of neurosurgery is quite high if you come into the corpus callosum. And maybe if we have a global treatment strategy, such as I have depicted now, maybe we should not take too much risk with the neurosurgery in such a very eloquent area, because we have then the combination of all these other therapies, because the ultimate goal is, besides overall survival, is also quality of life, which we measure here very accurate at the IOZK, but quality of life is also an issue. And so the neurosurgeons, as I have stressed in the beginning, safety and extent of resection, this is the tension where the neurosurgeon has to play and to take the appropriate decision.
And what is the median time of LGG progression in secondary glioblastoma?
Hard to say, and in part depending on which treatment has already been given for the low-grade glioma. So I would not make there a general prediction. It can be some years, but it can also more than 10, 20 years.
In your experience, what is the longest survival period of the patients with glioblastoma?
24 years. So the first patient that I have treated in Europe was in 2001. And I have heard, unfortunately, that this patient has died in 2024, not due to GBM. But that's the longest experience that there is. So this is novel technology, so there is no longer experience. There is another patient in the very beginning, so in the years 2002, 2003, who lives here in Stuttgart, who was a 15-year-old boy at the time when he was treated. At that time, he wrote, "I doesn't care that it is an experimental treatment because I will whatsoever die." And he wrote, I dream to drive my own car later as an adult. Well, now he has 2 children and works in Mercedes-Benz.
And regarding mRNA vaccination, is this dominant for the future?
Most likely, yes, for some tumors. I have explained that in the GBM, there are subclones that come and that go again. And these glioma cancer stem cells always can generate new subclones. The messenger RNA vaccines, where BioNTech is also working very hard in this research area, they, of course, have a photo of the messenger RNA at the time of taking the sample, and that's it. So if the tumor changes afterwards, eventually due to radiotherapy or chemotherapy, then your photo is not anymore compatible with the reality. So I think for some tumors, it will work very well. And I think in pancreatic cancer, for instance, they are working very hard. I think they are also yielding good results in melanoma. But I doubt whether all patients with glioblastoma can be helped with such a photo messenger RNA vaccine if you do not update your vaccine with new biopsies. But who knows, the future liquid biopsy is coming up, circulating tumor DNA is coming up. So science is not stopped. Everything is always under evolution.
Then there's a specific question regarding, I think, mebendazole. If mebendazole have any side effects?
Effects. So would fenbendazole have any effect? Well, so fenbendazole is a variant of mebendazole. So we work here with mebendazole. I think there is no comparative data between fenbendazole and mebendazole. So in fact, honestly spoken, I cannot completely answer that question because we have not done that.
Yeah. Thanks. So regarding the tumor creation process, so what part of the tumor creation process creates a heterogeneity?
Well, so that is a very good question, and I would dream to have the answer. There is certainly so. First of all, we do in fact not know why a brain tumor starts to grow. We know from the epidemiology that radiotherapy can induce a glioblastoma. That we know. We think that cytomegalovirus infection and eventually other viral infections also can induce or trigger glioblastoma. So that's one element. We do not know exactly what causes the glioblastoma. What is certainly the case is that glioma cancer stem cells move to the niches where there is a lot of hypoxia in the subventricular zones. And from there, they give the rise to cancer subclones, and these cancer subclones can go back to more glioma cancer stem cell phenotype. And then they start again as another tumor subclone. So there, something is happening. And in this subventricular zone and in this formation of these cancer subclones, they cannot do that on their own. They need the support of the surrounding tissue, the hypoxia, the inflammation, all these bad inflammatory cells, the microglia that are all somewhere dysregulated and allows and facilitate this formation of these subclones. And due then to the formation of these subclones, these tumor microenvironments, cells become also more dysregulated. And so the one dysregulation stimulates the other dysregulation. And that is how it somewhere occurs. So that is also why we have believed that you need to target both the tumor microenvironment, the hypoxia, and so on, the inflammation, and the tumor formation. So the anti-cancer treatment on its own certainly will not be enough.
And how do the other cell types become part of the tumor?
Well, as said, they sample together in the tumor volume because they support the tumor subclones, and at the same time, they make that the immune infiltration is blocked, so that they create their own community, so to say.
And what are the odds of someone with unmethylated GBM to be a long-term survivor with this model?
The odds, not zero, that's for sure. Also not 100%, that's also sure. So our data at the moment are, as I have shown, so the percentage 2-year overall survival is around 40%. And the longest patient that we have there in our cohort is now, because I have not mentioned that in the survival curve, but our x-axis was going up to 80 months, while in the trial from Northwest Biotherapeutics, the DCVax brain, and in the tumor treating field, the x-axis only went to 60 months. So we are already beyond 60 months, and I think the longest is almost 80 months surviving at the moment.
And then there's a question on the immune system. So what's the importance of memory T cells after vaccination?
I think very important, but not exclusively important. I think the memory T cells somewhere keep in mind that they have to fight against particular antigens. And as long as the memory immune cell exists, this antigen has no chance because the memory T cell will recognize the antigen and eliminate. Of course, the problem starts when the tumor cell downregulates this antigen, upregulates another antigen, then this particular memory immune cell against this particular target has not anymore a role.
Then a question on the recurrence. does your data include patients with recurrent glioblastoma?
No, the 90 patients that I have shown, I have also shown how I have selected these patients out of the database. They are all patients that were treated with immunotherapy as part of the first-line treatment. We have a whole group of patients that have come to here for treatment at time of relapse, first relapse or second relapse. They were not included in this analysis, but also in these patients, we observe some long-term overall surviving patients. And again, observed is not the same as evidenced, but if you can observe it for this particular patients, it's very good.
And do you see also the difference in methylation and unmethylation?
Less.
So is the cost of the manufacturing the vaccine not a concern?
It is an absolute concern for everybody, and it gives a huge stress to the patients. But of course, everything in medical activities has a high cost already for all the quality controls and the standards that you have to meet. The point is not so the cost. The point is who has to pay the bill. And there we come into the debate, which is for me also very difficult doing this type of work. And I have already stressed several times, observed is not evidenced. But our insurance companies only want to support patients with treatments that have been evidenced. But I have shown in my presentation that exactly for this particular disease, the evidence in randomized controlled trials is in fact almost not to be reached. So that's a little bit my frustration. How can we convince the authorities about the evidence which we observe, but which is not evidenced, that it is worthwhile for the patients to get this treatment? That is exactly the problem that we have as such. Our vaccine as such is not so expensive. If you look to some other types of drugs or some other types of cell-based products, then we are in fact cheap. But for the patients, if they have to pay that themselves, it is indeed, unfortunately, extremely expensive. And the only thing is that we, as a patient, doctor, caregiver community, have to convince the authorities to have another look to the problem, as with the randomized controlled trial, a method that has been developed in 1948. So I think so many years late, so many decades later, maybe we have to discover other methods to accept evidence.
So then the maintenance treatment phase, how much maintenance treatments are required?
Well, usually I say this depends on the response to treatment, this depends on the residual tumor, and this depends on the feasibility of the patient, and this depends on the risk that you have out of your survival curve. If your tumor is completely away and the patient is very good, then the frequency of this maintenance is lower than if the patient is just good, has still huge tumor in brain, but is just under control. Then you aim to be very prominent in your maintenance to keep it really under control. So there are no rules. We discuss that patient per patient and see what is feasible, what is, for in our point of view, what is recommendable. Ultimately, the patient decides. What I observe is some patients who are already very long out of tumor, they like to come further, for instance, 2 or 3 times per year, because they feel safe. Once they have a cleaning ICD for some days, then they feel safe to take the months in the future again till they come back. So stopping treatment for these patients seems to be much more difficult than starting treatment.
Then there's a question on another tumor entity. Does the treatment work better for an oligodendroglioma?
I have done many, I think more than 1 decade, maybe 50, 16 years ago, a study published on relapsed oligodendroglioma. It works also with oligodendroglioma grade 3, so the anaplastic oligodendroglioma, not the grade 2s. And we have also the impression that there is an extension of life. Yes, so it works also for oligodendroglioma.
And with this evidence you mentioned.
But the evidence is observation again. So these are casuistic. So there is no proper randomized controlled trial for level 1 evidence.
Then there's a question if we have a GBM trial, and if so, how can they enter it?
So, as I have explained in my slides, we have at the moment no ambition to do a small clinical trial, because what will we learn out of that? That would not be good, and we do think that the randomized clinical trial, which would be very nice maybe, is in fact not feasible. First of all, in the control group is too bad. And second, we have to adapt our treatment protocol during the disease course. And of course, in a trial, you have a fixed treatment protocol. But a fixed treatment protocol in a dynamic tumor is maybe not the best choice. So there, this tension remains, and the only strategy that we are doing here in Köln is, in fact, to sample experiences, to try to analyze them in a correct way, and to deliver these real-world data to the scientific community for scientific discussions. That is what we can do at the moment, and we will not start a clinical trial in short terms, because that seems not the best way to go forward for the patient care.
And then there are some technical questions. So where is the record available and when? And also, would you be so kind to share the pieces of the GBM treatment process in the IOZK?
So would you be so kind, please, to share the prices? So the costs. We will. So what we do for each patient is make an immune diagnostic evaluation. We have to see what is in fact the situation of this patient. What is the standard of care? Where is the patient in the standard of care? What is the clinical feature? What are the immunological features of the patient? So we make an immune diagnostic procedure. Then we make a treatment plan. And once we have the treatment plan somewhere in vision, so the strategic treatment plan, then we can also make a preliminary cost plan. We work here with the rates that are legally obliged to use by the German authorities in a legislation, the Gebührenordnung für Ärzte. So we are fixed with our prices because of this legislation. But of course, we can see which activities are expected to be done. So then we can also calculate what will the cost be expected. And this we make, in fact, patient per patient.
So there's no discount?
No, because we are ourselves bound on the costs that have to be calculated by this legislation. So this is, in fact, a very important question. We do not sell products, but we give treatments. And this is a completely different legislation. It makes it VAT. negative. So that is something. But so these treatments cannot be given outside the legislation, and that is so there is no discount because we do not sell products, we give treatments.
Thanks. And also sum it up, I see a lot of thanks and brilliant presentation that I do not mention during the question. So also a thank from our side to you, to the audience, that you join to our today's webinar to be announced for the Brain Tumor Awareness Month.